South Africa, for those who may be joining from abroad. And we'll just give everyone a minute or two before we start the webinar series. Thank you very much. Okay, so thank you very much to those of you who joined. You can see that the meeting is starting to fill up. I'd like to introduce myself. My name is Renee English. I lead the Division of Health Systems and Public Health here in the Department of Global Health at the Faculty of Medicine and Health Sciences. And it really is a privilege and honor for me to be able to facilitate this webinar, where Professor Lillian Dudley will be presenting on the work that she did as part of a group where they developed a consensus report that looked at achieving good governance and management in the South African health system. And so Professor Dudley has a long-standing history of working within the health system. She's a medical doctor who has a specialist degree in public health medicine as well as a PhD. And she, in fact, led the Division of Health Systems and Public Health here for a number of years, and has subsequently gone on to provide lots of technical support and input both to our national government as well as beyond. And so we're very privileged and excited to hear what the report has brought forth in terms of its findings, and to think through and talk about how we can understand those findings towards strengthening the health system. So thank you very much, and over to you, Professor Lillian Dudley.
Okay, good afternoon, colleagues, and thanks very much, Prof. English, for the introduction. So as Prof. English has indicated, I was part of a panel that was appointed by the Academy of Science of South Africa to review governance of the health system in South Africa. So I'm going to briefly go through the findings of the report, just starting with a little bit of the methodology, and then talk to the recommendations that the panel made. So a little bit of background first. Prof. English, can you just confirm that I am clear and that the slides are visible?
Yes, you are clear and we can see the slides. Thank you.
Thank you. Okay, so as background, I think we're all very aware that the right to healthcare is one of our basic human rights enshrined in the South African Constitution. And certainly a great deal has been done in the last 30 years to try and achieve this right. However, there are some very serious gaps in achieving this particular right. We know that we still have a very high burden of disease in South Africa, many diseases which are preventable, both communicable and non-communicable diseases. Even though we've improved access to care, there are a number of vulnerable groups for whom access to care remains an issue, including mental health care, where we know less than a third of people that require mental health care are able to access it. Quality of care persists as a problem within the health system, even though there are structures and programs to try and address it. I think we've been acutely aware. Recent social media reports have highlighted some of these issues again. South Africa as a whole remains one of the most inequitable countries globally, and this is also reflected within the health system, where the wealthy have far greater access to care than the poor. Health outcomes, even though we have improved a number of our health outcomes, when we compare ourselves to other equivalent middle-income countries, our outcomes are worse for the level of expenditure that we actually provide. So we have made gains, but there are still some very serious gaps within the health system. And the Academy of South Africa looked at this, and some of the questions which arose were the extent to which governance and leadership of the health system has contributed to both our achievements, but also our failures to address some of these very important areas. So the brief that the Academy of Science provided was firstly to determine and describe the magnitude, the spread, and the effects of the governance challenges in the health system. Secondly, to identify effective strategies or best practices that could be adapted or leveraged to address these challenges. And then thirdly, to make implementable recommendations on how to improve governance within the health system. And for those who are not familiar with the Academy of Science of South Africa, it is a legislated body whose mandate is in fact to provide evidence-based policy recommendations to government and other stakeholders. The Academy appointed a 7-member multidisciplinary panel, largely health systems experts, but from different disciplines. And this panel essentially undertook the work on a voluntary basis. The study included, firstly, a literature review to understand the historical context of governance of the health system, to explore different theoretical frameworks for governance and assessment of governance, and then also to look at evidence on governance interventions within the health system. We held a series of consultative meetings with key informants, drawn largely from 3 groups: the state, service providers, and citizens or clients. We then deliberated to reach consensus on the key challenges and recommendations, and also reverted further to literature which some of the key informants may have brought to our attention or which may have emerged in the interim. In addition, we included a chapter on strategic purchasing, given the importance of national health insurance and strategic purchasing as a key tool for the reforms which are required for the national health insurance. Dr. Mark Blecher led a team which focused on strategic purchasing in particular. And then lastly, the report was peer-reviewed both by national as well as international experts who contributed some very important additions to the report. So starting with our literature review and reflecting on where we've come from, the history of the governance of the health system in South Africa over the last 300 odd years really reflects a history of colonization, dispossession, and discrimination. And when we look particularly at the apartheid era, we see that governance of the health system became incredibly fragmented and certainly was very inequitable. So by the time we reached democracy in 1994, there was an incredible amount of work that needed to be done to ensure we had a unified national health system with a single governance system to oversee it. So a great deal of work was done in developing appropriate policies and programs, both to transform the health system, but also to ensure better governance. And you'll see in the white paper, it very specifically refers to good governance as one of the goals of the new health system. And the question, though, for us was, even though we've made progress and we're moving towards universal health coverage, to what extent have we fully addressed some of the governance challenges that we faced 30 years ago? From the literature, we also identified a number of definitions of governance, both in the health system, but more broadly. And the panel chose to be guided by the definition by Van Almen, which speaks to governance as policy guidance to the whole health system, including coordination between actors, the regulation of different functions, levels, and actors in the system, and the optimal allocation of resources with accountability to all stakeholders. So Van Almen really saw governance as not just one of the building blocks, but really the mortar holding all the health system blocks, building blocks together. We also became aware of some of the definitions which differentiated between governance of the health system, which really focused on the system of health service delivery, versus governance for health, which speaks more to intersectoral collaboration and governance of all other sectors which contribute to social determinants of health. Now, our original brief was to focus on governance of the health system in terms of service delivery, but clearly a lot of issues arose in terms of governance for health, and we've touched on that, but that is an area which probably needs much more work. We also looked at the frameworks, and after much discussion and debate, we decided to use the Michelson-Lopez framework for governance, which essentially identifies 5 key principles which they apply across the building blocks. The principles are firstly a strategic vision and policy design for effective governance, participation and consensus orientation, accountability, transparency, and systems to address corruption. So these are really the key principles for effective governance, which we then used in the report to analyze the data and have reported using those 5 principles. We also referred to the people-centered framework by Bigdeli and others, which looks more at the roles and relationships between various important players, and have tried to reflect on those roles and relationships in our analysis and reporting as well. So what were some of the key findings which came out of the original literature review? And I'm just highlighting findings largely from work in South Africa by a number of research institutions and academic institutions. So firstly, a key finding is that everyday governance in the South African health system is weak. So this is really at the coalface. The experience of governance by health managers and service users is that it is weak. In terms of system design, we have legislation which actually gives conflicting delegations to different decision makers. So for instance, the PFMA and the PSA give different delegations for the same functions to MECs and to the DGs in terms of human resource powers. So for appointing staff in the provinces, there's conflict between those particular role players. Extensive weaknesses in leadership and management have been identified in the health system. And then support systems, and one particular report by Helen Schneider looking at governance of human resources, which is a key element, as we're all aware of the health system, is particularly weak. So we may have some policies, and over the last couple of decades, we have developed human resource policies, but often they're not translated into practice effectively. We have a number of oversight structures. Many, however, are not fit for purpose, and here we're speaking about some of the statutory bodies which have been created, but also hospital boards, and also structures which are supposed to provide for community voice in governance, which are not really fulfilling that purpose. Increasingly, we've become aware of fraud and corruption throughout the health system and failures to effectively address that. The health HMI report found that stewardship of the private sector is weak. So even though we have some legislation to support governance, much of that has not been adequately applied. Now, having identified a number of these weaknesses, there were also very nice examples and case studies of innovation and good practice in governance at different levels, but particularly at local levels. And we were also able to identify some evidence of effective governance interventions from the global literature, which we could actually begin to look at in South Africa. From the interviews, overwhelmingly, stakeholders felt that this was a very complex problem, and some of the factors contributing to the complexity, first of all, were political, organizational, and structural. So we do have multiple levels within the health system with different political principles at each level, and disjuncture between these levels with political principles not necessarily aligning and collaborating. The structural complexity in terms of conflicting legislation and policies also further muddies the water with concurrent responsibilities and role confusion undermining governance. Community participation is also desired at each of these levels, and yet our structures are not really enabling that community participation. And then the parallel private and public sectors pose an additional stewardship or governance challenge. So with all these additional complexities, including the very complex nature of health institutions with multiple disciplines, etc., and the financial complexity, it really is what could be called one of those sort of wicked problems to try and resolve. Nevertheless, it was felt that from the health sector and from the National Minister of Health that there is a need to recognize that there is the enabling legislation in order to address this complexity. So looking at each of the principles that Michelson and Lopez provided, we've just summarized some of the key findings. Under the strategic vision and policy design for governance, it was felt that a coherent public value mission has not been adequately communicated or shared amongst all the stakeholders. So even though we speak about moving towards NHI, that becomes almost a goal in itself, and we're not really indicating what the overall outcome is that we want to achieve from the health system. Our policy designs in terms of intended decentralization were excellent, but there has been limited implementation of much of the intentions, for instance, around delegated authority. Managers at a district and a facility level, in fact, don't have the delegations that they were intended to receive. And this has left us with a health system where there's a lot of top-down decision-making within a rule-bound system, which really hinders innovation, integration, and also accountability at lower levels. The structures, I've mentioned that in terms of conflicting legislation, actually adds additional challenges. And we've also focused very much on the hardware of the system, putting structures and committees and bodies in place, but have not looked at the culture and the software of the system. So issues around trust within the health system, collaboration, having a common value system, these have not really received the attention that it should have. And we tend to focus on what people do. So we focus on the activities, we focus on the inputs, and because we don't have this shared value mission, we're really not looking towards the outcomes that we need to achieve and measuring people and rewarding or addressing issues around failure to achieve. The support systems, as we found in the literature, this was again echoed in the interviews, where key informants felt that support systems were not fit for purpose. So over and beyond the human resource system, policies and systems, procurement systems and health information systems were not designed and are not providing the kind of support for managers that they should. The regulatory bodies, even though we have a number that are in place, there are a number of weaknesses within those regulatory bodies, and some of them are perceived to lack independence from the executive. So they've been appointed by the minister and report to the minister. So in fact, de facto, there isn't real independence. But again, having cited a number of these failures in the strategic vision and policy design, the interviews also identified some successful examples where governance, particularly at a local level, enabled managers to be more responsive to their service users, and where senior managers enabled and supported teams and frontline managers to be more supportive and more effective. Looking at the second principle of governance, participation and consensus orientation, we looked at two aspects. One was participation and consensus orientation within the health system, so particularly around managers and leaders. And the second was the extent to which communities were able to participate. So around leadership and management, the biggest issue which emerged was instability of leadership, particularly at the higher levels. So we've had a huge turnover in DGs, acting DGs across most of the provinces. And the turnover at these levels has impacted on governance throughout the health system within the provinces. It also emerged that where managers were able to stand up and resist political interference, they had been punished for that. So either demoted or moved, and this has been particularly challenging. Many appointments were made of managers who lacked the technical and managerial capacity to fulfill the positions they were appointed to. But at the same time, we also found that there were examples where team leadership had created environments where there was a peer accountability, where there was shared visioning, and where there was a value-driven approach, which ensured good governance, transparency, and created learning organizations. So even though there were some certain governance and leadership challenges, there were also one or two examples where very effective leadership was being exercised. On the community participation side, even though we have the policies, the National Health Act does provide for clinic committees, hospital boards. There are challenges in how this is implemented, and it's inconsistent across the provinces and levels, because much of that, the decision making is delegated to the provinces to ensure implementation. So there are missed opportunities for community engagement, particularly for dialogue, in a respectful way. Many of the informants spoke about the spaces being created, but health service providers not really treating community committees with the kind of respect that is needed. Unfortunately, with the National Health Insurance Act, many of the weaknesses which are in the current National Health Act have not been adequately addressed. And we are hoping that as we go forward, these are one of the aspects that are going to be addressed in the regulations. But again, there are some very good examples of effective community participation, and I'm sure you're all familiar with the Richitse project, which looks at community monitoring of the performance of the health services and other NGOs, and really engages very effectively with decision makers to address any gaps in service delivery. So we have some really good examples that we can build on. Thirdly, accountability. So accountability is really where you've been given responsibility for a particular function, ensuring that you are delivering on that. So even though we have a number of accountability mechanisms, so for instance, the Office of Health Standards Compliance is supposed to assess quality of care. We know that very often the system is gamed, where people will lend each other equipment or supplies simply to meet the requirements of the accountability system. So the general perspective was that even though we have some of these systems, then they are failing to hold people to account within the health system. And it's not just around financial accountability. So the Attorney General does actually monitor the financial accountability and try and identify corruption. But more importantly, we also are failing to hold the system accountable for achieving the outcomes in terms of the common public service mission. And a major contributor to this was seen as the lack of competent appointees and the role of political interference in that, and that many of the managers that have been appointed are vulnerable to vested interests. So their accountability is not necessarily to the service user, but is more to political principles or other professional principles. We've also seen accountability weaknesses within the parliamentary system, and the example of the Digital Vibe scandal was cited, where people implicated in that, even though the Parliamentary Health Portfolio Committee was very aware of it, certain people were not held to account. So some of the inputs from governance experts that we received was that to ensure better accountability, one actually needs a range of accountability structures and mechanisms. So as I've mentioned, some of our statutory bodies essentially are appointed by and report to the Minister of Health. And in fact, there should be additional accountability structures. And we see in other countries where there are community or civil society accountability structures for some of these statutory bodies as well as for the rest of the health services. There were also other concerns raised that very important reports, such as the health market inquiry, hadn't received the kind of attention that it should have received, and that other committees, such as committees for the prevention and control of cancer, were regarded as toothless. So even though structures are established, they're not, in fact, enabled to implement some of the mandate that they're given. The fourth principle is around transparency, and this clearly overlaps with accountability as well. But there were two key areas where the informants felt that transparency was a problem. So largely around the appointment processes, which we've touched on under the other principles as well, but the issue of a lack of transparency in appointment processes where which then enable cadre deployment and patronage networks to function. And overall, there was a sense that if we don't equip the system with the right people, if we are appointing people and there aren't transparent processes, they are not going to be able to deal with the challenges and the complexity of the health system. The other area where transparency was a problem was around health information systems, and particularly the use of health outcomes data for performance monitoring, as well as for, in the future, for contracting. So again, highlighting the importance of transparency of data around quality of care and performance of the health system. And then the last principle was around addressing corruption. And the key issues that came out here, in addition to concerns about the extent of corruption which has developed in the health system, was the vulnerability of whistleblowers and the lack of protection for whistleblowers. So a number of key informants cited their own experiences of being targeted or being moved where they took a stand, a principled stand on issues to prevent corruption. So the sense was that the current measures to address corruption are blunt and in some ways may in fact be quite negative. So a tightening up of the regulations, the rules, etc., have actually made it more difficult for managers to implement decisions, for instance, around procurement systems, where a lot of the corruption has occurred. Tightening up the rules has meant that it's so complicated that many managers don't actually know how to procure the goods and services that they require. And the sense was that we need to look at more innovative ways of managing and preventing corruption, because we've now moved to a system where corruption is occurring, but managers are actually having difficulty doing their jobs and are being more compliant than trying to achieve the kinds of outcomes that are needed. So out of those findings, the key strategies that we really came down to was, first of all, we need to get the governance systems right. Even though we've established a number of structures and systems and policies, much of that needs some adaptation and tweaking, given that they're not necessarily fit for purpose any longer. But most importantly, it was about getting the right people with the right competencies into the right places, and then also empowering managers and teams to be more effective, to be more accountable, and to promote transparency and participation within the health system. So it really is, at the end of the day, a call for the National Department of Health to focus on the governance structures and what we should be achieving overall in terms of a public service mission, but then delegating and providing clarity around the roles of all the implementing agencies, now people with the right people to actually deliver, and to have the oversight bodies functioning effectively. I'm just going to touch briefly on the chapter on strategic purchasing. I mean, this could be an entire talk on its own, so apologies for rushing through this. I'm not going to try and explain strategic purchasing. I think we've given a definition in the bubble. But essentially, the National Health Insurance Act provides for a split between purchasers and providers and sets up the National Purchasing Authority as the National Health Insurance Fund. And the implications of this are that there are going to be changes in the governance powers and functions across the spheres of governance, of government at different levels, but also at the level of institutions. So, for instance, hospitals will require greater autonomy and decision-making powers, because the National Health Insurance Fund is going to contract directly with these institutions. The NHI will also be developing new provider payer models. So as opposed to simply allocating budgets within the public sector, we're now going to be looking at case-based payments through DRG groups for hospitals and other forms of value-based payments, which really start looking at performance at institutional level or district level, rather than the current incremental budget allocations. With the public and private mix as well, clearly there needs to be a system of governance which addresses both and which enhances overall governance of the system. So some of the reforms that are required is, first of all, to establish stronger, more semi-autonomous provider institutions. So we need to change the legal status for hospitals, including the powers and responsibility of the senior management as well as the hospital boards. So really it's a complete change in the governance structures, whereas current hospital boards are purely advisory. In the future, in the NHI, they are actually going to have to be part of the decision-making and accountability process. We're going to need better governance of contracts linked to performance targets. Funding is going to then be linked with performance through these reimbursement forms. And our information systems are going to have to provide us with the kind of outcome measures which are required for assessing performance and allocating funding based on the performance. And ultimately, we are going to need capacity to manage this entire process. And much of this capacity does not exist at the moment, either within government or within any of the governance structures. So an entire process of capacitating both service providers and governance structures to oversee this new strategic purchasing system is going to be required. So I've touched on these in the previous slide, but really greater independence needs to be addressed. Governance of the National Health Insurance Fund itself is going to be an issue. We cannot have the board appointed by the Minister of Health and reporting to the Minister of Health, as most of the other statutory bodies have been, because that's really essentially going to mean that the provider is actually overseeing the purchaser, which is going to be a conflict of interest. The powers of the spheres need to be clarified. We've already highlighted that currently there's confusion, role confusion because of conflicting legislation. So this really needs to be addressed in the legislation going forward. The autonomy of structures I've mentioned. And then if ultimately strategic purchasing is not established as something different to the current government procurement system, all the pitfalls of the current procurement system, but including the gaps for corruption, as well as the overregulation, will complicate the provision of services. So a lot of work around strategic purchasing is going to also impact on governance at every level within the health system. So in summary, if we look at these principles under strategic vision and policy design, the absence of a unified public value mission was a key finding, as well as challenges in the design of our governance system, including inadequate delegation of authority. Transparency and accountability, political interference, and a lack of transparent processes, including in appointments, undermines accountability and trust in the health system. In terms of participation and consensus orientation, inadequate community involvement and hierarchical and top-down management approaches really restrict stakeholder engagement at every level. And then in terms of corruption, this remains a significant issue, which is exacerbated by insufficient protective measures for whistleblowers and a lack of decisive action against corrupt practices. And there's a need for better measures both to prevent and to address corruption. So even though we see this as a very complex problem, the panel felt that the foundations for good governance are in place. We have established systems and structures. We have made some gains, but we now need to focus on where the governance system is not addressing the needs for the future. The stakeholders that we engage with all expressed a need for urgency in addressing these failures, particularly as we move towards NHI, which presents new governance risks over and above the ones which we've identified, but also presents some challenge opportunities for us to be able to address some of the existing as well as potentially future risks. And there was a call for more innovative as well as inclusive approaches to governance, which are better designed both for the current context and for the future. I'm going to skip because I realize my time is short. So the panel made 8 recommendations. First of all, develop a common vision through engaging all sectors, partners, and stakeholders so that we all share and buy into a common public value mission for the health system. Update the legislation and governance structures to insulate them from vested interests and give them more executive authority rather than advisory functions. Delegate authority appropriately within the health system and within levels of the health system. Get ethical people with appropriate competencies into the leadership and management positions in the health system, so the right people in the right places, and surround these managers and leaders with functional fit-for-purpose support systems so that they can be effective in their jobs. There was a need to focus on the software more, so building teams, attending to relationships that make complex systems work. So we need the hardware, but we also need the software. Community engagement needs to be enabled to ensure appropriate, respectful, and responsive health services, as well as to enable communities and service users to monitor the outcomes and processes within the health system. And then lastly, to effectively address corruption by acting on dereliction of duty and protecting whistleblowers. We realize that many of these sound very challenging to implement, but the failure to grasp these opportunities to address governance will render universal health coverage even more unlikely and can lead to the situation in South Africa where quality healthcare is available only to a minority. So our recommendation is really to start implementing, and this is really speaking to all stakeholders, and to essentially have a longer term view in terms of addressing all of these things. We were also really overwhelmed by the enthusiasm by many of the stakeholders to be able to address these issues, and the sense that there are many skilled people within the health system who really do want to work hard and ethically and ensure good governance. So the question that the panel was left with and wanted to share was, if not me, then who? And if not now, then when? And we are very convinced that most South Africans and most health service providers and other stakeholders would like to stand up now. Thank you. Just to acknowledge my fellow panel members and the ASIF Secretariat.
Thank you very much, and I think it deserves a round of applause. Thank you very much, Lillian, for presenting on behalf of the panel members as well as the ASIF the Secretariat and group. And this is very important information, not new, but very important to cause us to pause and reflect and think about how do we, as you say, we have to take some responsibility as well as healthcare workers. And so how do we take this forward? What do we do? And then how do we do so in our various environments? And you are speaking to an audience in a higher education institution, and a research institution. So how do we take that forward? So thank you very much for that. I'd like to open up now for any questions or comments. If you have a comment, you may type it into the chat box, but it would be great for you to ask some questions. And while we are waiting for people to ask questions or offer their reflections or their thoughts on what was presented, I'd like to ask one question in the meanwhile, Lillian, which is, what has the response been to this report from the various sectors, particularly from the highest level within the health ministry, and linked to that, clearly, in order to shift things and change things within the public sector, and particularly within the health sector, which this report is about, it does need buy-in and leadership from other sectors and other government departments such as National Treasury or the Department of Public Service and Administration. So what has that been like? Because they, from what I understand, are integral to driving the change in terms of setting vision, but also in terms of responding from a policy and legislative point of view. Thank you.
Okay, thanks, Renee. There has been a great deal of interest in the report from a wide range of stakeholders, largely within the health sector. And we have presented it at a number of forums. It was first launched in July. And yeah, I think a lot of both government and other academic research institutions, NGOs, participated in the launch. We have also presented it at the National Minister's recent retreat with all the new MECs and DGs of health. in September. Yeah, I'm just trying to think when that actually occurred. So that was fairly recent. So there was sufficient interest for them to include a presentation on this on the program, and certainly I think from the DGs and new MECs, there was a lot of interest. I think one of the main questions which they raised was the kind of, so what? Now, what do we do? And at the moment, the report does make these 8 sort of recommendations as to what should happen, but it doesn't give a detailed plan as to how to go about doing that. And I guess for some of the newer politicians, they were really asking for, okay, give us the how-to now. And I think that is probably part of the next stage of work that needs to happen, even though we've looked at the evidence and we can identify some interventions. And I do think there's both a need for more research around what works and what doesn't, because certainly a lot of the evidence that we looked at was really identifying what some of the problems were, and far less was about effective interventions which had been evaluated to inform policy. So there is a gap there. And as an academic institution, that may be something you want to think about as well. But overall, I think the reception has been good.
Okay, thank you very much. I see Dr. Therese Fisher's hand is up. Please go ahead.
Hi, Lillian. Thanks for the presentation. I was also listening in at the launch. So when one listens to the report and the many other reports that are coming around the health system, one is just has a sense of being overwhelmed. It's just one has a sense that there's just so much to do. And I suppose my question is, who is the conductor of the orchestra? Because there are so many different aspects around universal health coverage. I mean, there's focus on a specific component. But if one looks at the big picture, and I mean, and some of the key recommendations are so fundamental to the bigger picture, I mean, who drives it? Who's the person that will be held responsible if it doesn't materialize? And so if one looks at that ask the question, because somebody must be guiding. We can all be doing our research and choosing what's of interest to various academic institutions. But if we don't have some entity that is really pulls it together and highlights the areas that need to be further researched, or some pilot studies around doing some implementation, I just worry that a lot of this will just go on, and in a few years' time, ASIF will ask for another report of where we are. Thanks, Lillian.
Thank you, Lillian. Before you respond, I see Prof. Lungiswa Nkonki's hand is up as well. Please go ahead.
Thank you. Thank you, Renee, and thank you, Lillian, for a fantastic presentation. And I have a comment and a question. My first comment is just, I think for me, it's really striking to see, I think now it's over a decade of several reports pointing to a sort of lack of stewardship at a national level, and without and all these reports tend to call for a stronger and robust stewardship role, and without really that materializing. And I wonder if there is a different handle in your review of the literature in other countries, in contexts where there has been a challenge with stewardship. Are there better ways? Are there alternative ways of trying to achieve that, of trying to support the institution that's struggling with that? I sort of feel a bit fatigued by reading consistently pointing out of the same or similar issue. So that was my comment that turned into a question. The other, I think the second thing I wanted to point out is that I wanted to know from the panel if there is a plan or if there was a funding allocated for advocacy. And because I think my experience of having served as a panel member in the health inquiry is that we concluded our work, we presented to MECs, to the minister at the time, the minister was present. And then after that, we all went to fulfill our various different roles and didn't have a continued role to continue with advocacy for that work. One of my regrets from the time of the inquiry is that actually the one good thing we did, you said in this in your work they asked the how to. In the health market inquiry, we actually provided a very detailed how to implement the recommendations, which are still not implemented, even though there's a how to. But I think what was missing for me, if what I would do differently today, is I would have a costed plan, because what I've seen lately as a comment on why some of the things, for instance, we suggested a supply side regulator, having thought through carefully about weaknesses and challenges with regulating the private sector, and observed in other countries that there is a supply side regulator that is an independent, that helps national departments carry out that role. One of the most common reasons that I've seen out there as being the reasons why that hasn't been done is that it would have taken 10 years to achieve that. It would have needed additional funds, and there's no clarity what additional funds. And I wish we had actually costed how much it would have taken to do that. And interestingly, now it's been 7 years, and so since the health market inquiry, and the thinking at that time was that the national health insurance was going to happen in the next 3 years, and now we're 7 years on, we're still sort of highlighting similar problems. So thanks, Lily.
Thank you, Lungiswa. You may respond, Lillian. Thank you.
Okay. Thanks very much, Therese and Lungiswa, for those questions. I think you've really kind of touched on some of the big issues in terms of how does one take this forward. So Therese, you asked about, who's really the overall conductor, where does the responsibility lie? And, clearly stewardship of the entire health system should lie with the National Ministry, the National Minister of Health, and possibly the Parliamentary Portfolio Committee in terms of political oversight as well. So, we've, obviously tried to get to the political principles. And as I said, to some extent, there was an interest in the report and its implications. We haven't been to the Parliamentary Portfolio Committee yet, though. So I think that is another level that we should go to, because I do think that the Parliamentary Portfolio Committee does have a role to play then in ensuring that there is effective stewardship from the National Ministry across the entire health system. But having said that, and I think that also picks up on Lungiswa's comment, that, this is not just about one stakeholder or role players. I think there are multiple actors that need to contribute. And when we think about academic institutions, the question about you take corruption within the health system or effective leadership and management, to what extent are we, in fact, equipping our graduates? And I know this is work that Stellenbosch has been busy with for more than a decade, with the kind of competencies that's going to ensure that they are ethical, not just in their clinical practice, but in their decision making if they are in management positions, etc. So, I know when we were working on the graduate attributes, I can't remember how strongly ethics came into it, but I think certainly that has emerged as a very important aspect of competencies that we need in our leaders, our managers, and our health service providers. So essentially there isn't a silver bullet. There isn't one person that this entire governance challenge depends on. It depends on multiple role players, and ideally we would like to see the stewardship or the leadership coming from the National Department, the National Minister of Health. But at the same time, I think Lungiswa was suggesting that maybe we also need to be looking at other levels. And, I do think that there's a role for civil society, and we engaged with a number of civil society role players as well who were very frustrated. But one of the challenges they also identified was that, first of all, government didn't create or provide spaces for civil society to adequately engage as governance partners, but civil society itself, because of the competition for space, in fact, weren't working together. So I think civil society can be far more effective as a governance partner if there was less competition and more collaboration within civil society around some of the governance issues as well. And certainly, I think we have seen some examples of bottom-up governance, and I mentioned the Richitse project, which is really, I think it's been implemented across 8 provinces already, where by engaging with communities and sharing monitoring data on the health services with communities, communities are actually able to call the health services to account to them. So there are different ways of looking at governance and levels at which we can start addressing some of the governance challenges. But at the same time, I think, Lungiswa, you make a very important point that it does need a plan. It really would be helpful to identify what some of the low-hanging fruits are. Are there some quick wins that can happen, and what are the longer-term measures that need to be implemented? Your point of costing, we hadn't actually considered that, but clearly at the end of the day, the feasibility of implementing and the affordability of implementing some of the measures that are needed are also going to inform the extent to which policymakers adopt the recommendation. So thanks for suggesting that, and I think we can certainly look at that. The funding for advocacy, no. we gave our time voluntarily, and it seems like we're giving our time voluntarily again to disseminate the report. So that is a bit of a gap, and but we are working with the Academy of Sciences South Africa to put together a dissemination plan, and I think some of your suggestions are going to be very helpful in terms of populating that and suggesting what we should be doing in addition to just communicating it. I think I've picked up on those questions. Have I fully covered you, Therese and Lungiswa?
Yes, thank you. Thank you, Lynette.
All right, so thank you very much. Yeah, Therese gives a thumbs up. So we are at the top of the hour, and we are about to close. So thank you very much for the presentation and for the inputs and the reflections, and also for some of the learnings that have come out of this. As the presentation continued, as the discussions took place, now I do think that we have a health systems problem, but we also have a public sector problem. It's sort of woven into your recommendations in a way that there has to be this high level leadership. But I would imagine that these problems are the same in education and in other sectors, and we know that anecdotally as well from the reports. And so I think there are two challenges that I'd like to put out. And the first challenge is to us who work in health, to really try to work more collaboratively, whether it is in how we teach the graduate attributes, but how we collaborate across the various research spaces where we're doing this work. And the second is that, I think that we need to infuse this way of being in the public sector, the ethics and practice, into other faculties, into the university, because it's not just health professionals who end up working in the health system. It's a range of other professions who ends up working in the health system. And so that's sort of my closing reflection for this really important presentation today. So please just let's give Professor Lillian Dudley another round of applause and thank her for her voluntary time, which we appreciate, and wishing the work of ASAF and others in this space much fortune in trying to assist in fixing the health system. So thank you very much, everyone, and enjoy the rest of your afternoon. Thank you, Lillian.
Thank you very much.
Bye. And don't forget to register for CPD points. We have one hand that went up. Oh, Vic. Okay, not meant to go up. All right. Thank you. Bye-bye.